Welcome back to the fourth session of the 7th Annual Conference of Rheumatology. It's my pleasure to present the next chairperson, Dr. Khawla Al-Ghanim. She's an internal medicine consultant, rheumatology consultant at King Fahd Military Medical City at Dhahran. And Dr. Tariq Al-Bishri is an internal medicine consultant, rheumatology consultant, and head department of rheumatology at King Fahd Armed Force Hospital at Jeddah.
Good afternoon, everyone. I hope you did enjoy the previous session. Our next session will be a challenging one, and it's my pleasure to introduce our first speaker, Prof. Ernest Choi. He is the head of rheumatology and translation research at the Division of Infection and Immunity and director of the Cardiff Experimental Arthritis Treatment and Evaluation Center at Cardiff University School at UK. Also, he served as a clinical expert to the National Institute for Clinical Excellence in the UK and many drug companies. He has published widely on the treatment for rheumatic diseases in major medical journals, such as the New England Journal of Medicine. He's a frequent lecturer in the treatment of rheumatic diseases. You are more than welcome, Prof. Choi.
Hello, I'm Ernest Choi. I'm Professor of Rheumatology at Cardiff University in the UK. It is my pleasure to be invited to give this talk on drug-free remission in rheumatoid arthritis. So these are my disclosures. So as rheumatologists, we all know that remission is the primary treatment target in rheumatoid arthritis, and this is enshrined in many clinical recommendations, both ACR and EULAR. However, if the patient has been judged to be in sustained remission or persistent remission, then at least in EULAR, it recommended the patient will first have glucocorticoid tapered if they are taking glucocorticoid, followed by considering tapering biologic DMARDs or targeted synthetic DMARDs, especially if they are used in combination with a conventional synthetic disease-modifying drug. And if they are still in remission, then conventional synthetic DMARD tapering could be considered. And ultimately, obviously, that would lead to the state that we would be known as the patient being in drug-free remission, which is the focus of my talk. A number of studies have looked at how feasible this is. So this is a study looking at tapering of biologic DMARD in rheumatoid arthritis over 2 years in patients in routine clinical practice. And in this study, they identified certain factors that were associated with successful or failure in tapering of biologic DMARD. So first of all, on the top left-hand panel, gender. So if you are male, you are more likely to have a successful taper compared with female. The second is the number of previous biologic DMARD treatment. So if you have failed more than one biologic DMARD, then you are far less likely to get successful tapering. So in fact, your chance of successful tapering is only 24%. If you look at imaging, either inflammation or damage as assessed by MRI scan was associated with the chances of the individual getting successful tapering of their biologic agents. With the presence of inflammation or damage, the patients are far less likely to get successful tapering. And in fact, if you look at the inflammation score or damage score, any signs of inflammation or damage your chances of getting successful tapering is 20% or less. Now, in real life, one thing we recognize that perhaps one of the issue with the current criteria to recommend tapering and why some patients fail to taper is that we routinely use disease activity scores such as DAS28 to define remission. But many patients who have DAS28 defined remission still have active disease. So this study looked at the patient's number of swollen joints. Even though they may be in DAS28 remission, you can see that in fact, often the patient still have a swollen joint. And in fact, in some cases, they can have 4 or more swollen joints, suggested that they are not in true remission. And in fact, study using ultrasound have shown that many patients who fulfill the DAS28 remission criteria still have ultrasound evidence of synovitis. So that begs the question whether using imaging that will help us to better manage disease, give the patient a better outcome, and therefore more likely to taper treatment. Now, a couple of studies have looked at whether the addition of ultrasound can help to achieve outcome. So this is the TASER study in which 111 newly diagnosed patients with rheumatoid arthritis or undifferentiated arthritis who have symptoms of less than 1 year were randomized to standard practice group, a treat to target treatment group, or they will have additional musculoskeletal ultrasound. And if the patient have evidence of synovitis on ultrasound, regardless of whether they are in low disease activity or not, treatment will be escalated. So the patient will only have no change in treatment if they are in low disease activity and they have no evidence of synovitis on ultrasound. However, this study, if we look at reduction in DAS score, the standard practice arm did not differ from the arms that had the musculoskeletal ultrasound. And in fact, if we look at physical functioning using the health assessment questionnaire, there was also no difference between the two groups. So the conclusion in this study is that there's no difference in DAS 44 score, HAC or ACR core set variable at any point during this study. A second study, the Arctic study, actually found similar results. So in this study, a larger study, 238 newly diagnosed DMARD-naive patients with rheumatoid arthritis were randomized to 2 arms, one arm with the treatment target of a DAS of less than 1.6 and no swollen joint. And the second arm is clinical remission as well as imaging remission. And the primary endpoint was clinical remission plus no swollen joints and no progression of joint damage at 16 and 24 months. And if you look at the primary endpoint, the ultrasound type control group did not differ from the conventional type control group. And this is the dynamic of response in terms of DAS score over the 24-month period. So it doesn't suggest that the addition of musculoskeletal ultrasound will add to clinical criteria of remission, at least in the outcome of patient in the long term. And Georg Schett used this onion diagram or shell model of remission state to suggest that perhaps even with imaging ultrasound, we are not truly assessing whether the patient have microscopic inflammation in the joint. So he said that at the moment, we are using clinical remission criteria in everyday practice, and we have used and added imaging criteria and perhaps even with serological measure of remission as the next step in remission. But ultimately, if you want to have a cure or absolute remission and therefore achieve drug state remission, we need to suppress or regulate the immune response inside the joint in order to achieve that goal. Now, there is some molecular study that have suggested or to base this argument on. So this is a study published in Nature Medicine last year, using synovial biopsy in patients with active rheumatoid arthritis and in remission to look at the characteristics of cells within the joint. And what is suggested is that there are certain subset of monocytes or macrophages inside the tissue that are associated with remission. So you can see that cells that have a high expression of MERK and CD206 or 163 were highly associated with the remission state in this patient. And in fact, if you use a ratio of these double positive cells versus cells that are negative for these, then the patients this score is associated with the likelihood of this patient getting flaring. And you can see the distribution of these cells on the lovely histology shown on the bottom panel. And you can see that the macrophages of these expression are mainly expressed in the lining layer of the patient's synovial joint. And one of the reasons why these cells are associated with remission is that these double positive macrophages produce less pro-inflammatory cytokines when they are stimulated. So in this experiment, the synovial tissue were digested. They were stimulated with LPS, which is a bacterial cell wall, and it studied the release of cytokines, interleukin-6, IL-1 beta, TNF, GM-CSF, amongst many others. And you can see in blue, these are the MERK and CD206 double positive cells, and they show significant reduction or less production of pro-inflammatory cytokines than other macrophages. So it suggested that there may be immune cells or immune macrophages that may be regulating inflammation in patients who are in remission. And indeed, similar to the macrophages, there are fibroblasts within the synovial lining layer that is associated with remission versus active disease. So if you look at the genes that are expressed by fibroblasts on the top left-hand panel, patients who have active arthritis have very different gene expression, which are shown all in red. But patients who are in remission tend to have active inflammation, have expressed genes that are shown in red, and patients in remission have a distinct pattern of gene expression that is shown in blue. So again, it shows that in the synovial tissue, there may be fibroblasts that are associated with promoting inflammation, but there are also fibroblasts that may be regulating and controlling inflammation. And understanding the relevance of these may help us to predict which patients would be in remission or in sustained remission. A recently published study in the Journal of Autoimmunity tests the notion of gene expression of a way of predicting remission in rheumatoid arthritis. So this is a study looking at patients from the time of onset of rheumatoid arthritis, and they have followed them up. It follows standard criteria, and some of these patients managed to taper off the disease-modifying drugs and remained in remission. And it looked at the gene expression from CD4 lymphocyte in this patient, and what they find was that the gene profile of circulating CD4 lymphocyte in circulation of this patient was associated with sustained remission in this patient with a ROC curve on the left-hand side and the prediction of drug-free remission on the right. So this suggested or give credence to the notion that molecular or immune remission may well perform better in predicting whether the patient will achieve drug-free remission. Now, having said that, you will notice that all the study have been done in early arthritis patients. And this is based on the principle that we know that rheumatoid arthritis started many years before the patients become symptomatic. And in the pre-disease stage, there were already immune dysregulation with raised CRP, as well as the presence of rheumatoid factor and anti-CCP antibody. By the time the patient becomes symptomatic and presented to rheumatologists, the immune response have been amplified already. So there's a window of opportunity to try to get control of the immune reaction before the amplification becomes so big that it becomes very difficult to reverse this. And this established the window of opportunity principle, and where all the international recommendations suggest that the patients should get the disease diagnosed early and treatment be started early once the diagnosis is made. And we can see the benefit of early diagnosis in this study in terms of drug-free remission. So this is an early arthritis study in the Netherlands called You Act Early. So patients in this study are all DMARD naive early arthritis patients within 3 months of symptom onset. They were randomized to receive either methotrexate or tocilizumab, or methotrexate plus tocilizumab. And you can see that patients who were given tocilizumab or tocilizumab plus methotrexate in the color lines achieved very high level of sustained remission. That is remission assessed at 2 separate occasions at 80% if you manage to get this patient early. Now, importantly, in this study, when they follow up this patient in the long term, they look at the proportion of patients who achieve sustained drug-free remission, and show that, in fact, in the arms that were treated with tocilizumab or tocilizumab plus methotrexate, there were much higher percentage of patients who achieved sustained drug-free remission, close to 30% in these groups, compared with only 11% in the methotrexate treated group. It suggested that, therefore, early control of inflammation can lead to drug-free remission in the future. And this early intervention concept was again shown in the recently published IMPROVE trial. So this is a study again from the Netherlands, when they look at patients in the early arthritis clinic. So the standard practice is to give this patient a combination of tapering, prednisolone, and methotrexate. So if the patient achieved remission, all is good. But if the patient did not achieve remission, then these patients were randomized to a more aggressive treatment arm with a combination of disease-modifying drugs. And if they don't respond to this, then they get adalimumab, or they will stay on standard treatment as in arm 2. Now, what is really interesting in this study is it looked at drug-free remission in this study. And you can see that for drug-free remission, early intervention is really important. So it shows that in the patients in early response to methotrexate, something like 40% of patients achieve drug-free remission. But if we look at patients who were in arm 1 or arm 2, whilst there is a chance of achieving a drug-free remission, this chances is reduced to less than 20%. So it really highlights this important principle that early intervention is absolutely important. Now, we know that early intervention is already associated with sustained remission in many early arthritis studies. Now, importantly, what we know are also some risk factors associated with failure to achieve remission, even in this very early arthritis patient. And one of them is weight. So obesity reduces the chance of achieving sustained remission in early arthritis, and it's something that we need to address in the future. So whilst early diagnosis and early intervention have been established as a principle and recommended in many national and international guidelines, real-world study across Europe shows that, in fact, this goal has not been achieved, and many patients still have a long wait to see a rheumatologist and then before they get started on treatment. And it's something that we really need to address. Studies that have looked at barrier to early diagnosis and early treatment have identified that, in fact, this delay is different in different countries, and individual countries need to look at their own healthcare system and find a way of getting patients diagnosed early and treated. And this is a national issue that each country will have to address. So in summary, sustained drug-free remission is the ultimate treatment goal in rheumatoid arthritis, and it's as close as we can get to a cure. And drug-free remission is uncommon and only achieved in approximately 10% of patients. Deep and sustained and early RA are associated with higher chance of remission. So this established the principle of window of opportunity. And the time to diagnosis RA from onset of symptoms remains a big barrier for us to achieve the goal of drug-free remission. Thank you very much for your attention.